Welcome to the deep dive. Today we're talking about that squiggly line printout you see everywhere in medicine. The ECG, or EKG, some people say.
Right, the electrocardiogram. Looks kind of messy, maybe, but it's incredibly powerful.
Yeah, it's often the absolute fastest way to know if someone's in serious trouble, like a major heart attack or some dangerous chemical imbalance.
Exactly. It's like learning the heart's electrical language. And once you can read it, especially those key patterns and, the math behind the grid paper, it gives you this immediate insight, helps you spot things that need action now.
And that's really our goal for this deep dive. We're using our sources, core principles, high-yield clinical stuff, kind of thing you need for quick assessment, to translate those squiggles into something you can instantly recognize and act on.
Turning complexity into clarity fast.
Okay, let's unpack this, starting right at the beginning with the paper itself, the grid.
So the whole system relies on standardization, that grid paper. It's the same everywhere, same calibration.
And that's vital,
Yeah.
right? Because all the diagnostic criteria, they depend on those little squares being consistent.
Absolutely vital. Think of it like a graph. The horizontal axis, that's time. And the paper always moves at 25 millimeters per second. Always.
Okay, and the vertical.
That's voltage. And the standard is 10 millimeters equals 1 millivolt.
Got it. So then we zoom in on the grid, those tiny little squares, 1 millimeter by 1 millimeter. What do they represent in, like, real terms?
Okay, that small square, that's your basic unit. Sideways, horizontally, it's 0.04 seconds.
0.04.
And vertically, up and down, it's 0.1 millivolts. Then you have the bigger squares, 5 small ones across.
Yeah.
So that makes one big square, 0.20 seconds across, and 0.5 millivolts high. And, that 1 millimeter height, that 0.1 millivolt, that's often the critical threshold, like is ST elevation 1 millimeter or not. That one tiny square can change everything.
Wow. Okay, so that standard is literally the line between, let's watch this, and, okay, emergency action needed. Powerful stuff. So how do we use this grid for something basic, like calculating heart rate quickly?
Well, if the rhythm is regular, the 300 rule is your friend. Super fast.
How does that work?
You find an R wave, the big spike, that lands right on a heavy grid line. Then you count the number of large squares until the next R wave hits.
Okay.
And you just divide 300 by that number. So if there are, say, 4 big squares between R waves, 300 divided by 4.
75 beats per minute. Nice and simple.
Yeah. But what if the rhythm is all over the place, like an AFib? That R to R distance keeps changing.
Right, the 300 rule wouldn't work then, would it? You'd get a crazy number.
Exactly. It's useless there. So for irregular rhythms, you need the 6-second rule. Remember how 30 big squares is exactly 6 seconds?
Right, because 30 times 0.2 seconds.
Yeah, 6 seconds.
So you just count how many QRS complexes, those R waves again, fall within that 6-second strip, that 30 large square segment.
I count the beats in 6 seconds and multiply by 10. That gives you the average beats per minute. Works for any irregular rhythm.
All right, so we've got the map, the speed, the rate. Now let's look at the actual electrical journey, the conduction, starting with those key intervals, the PR and the QRS. What are the normal timings we're looking for?
Okay, the PR interval, that's the time from the start of the P wave to the start of the QRS. It reflects conduction through the atrium and, critically, the delay in the AV node. Normal is 0.12 to 0.2 seconds.
Which is 3 to 5 small squares on the grid.
Exactly, 3 to 5 small squares. Now, if it's consistently longer than that, longer than 0.2 seconds, that's a first-degree AV block.
First-degree block. Sounds bad, but often it's, not that big a deal, clinically speaking. Maybe someone's just really fit or on certain meds.
That's often the case. You see it in athletes or, people on beta blockers or calcium channel blockers that slow down the AV node. It's usually just a delay, not a true block. But the opposite. A short PR interval, less than 0.12 seconds.
Okay, less than 3 small squares. And if that short PR comes with that sort of slurred upstroke on the QRS, the delta wave.
Then you're thinking Wolff-Parkinson-White syndrome, WPW. There's an extra electrical pathway, an accessory pathway, that bypasses the normal AV node delay.
Right, and there's a really important warning that comes with WPW, isn't there? Especially if the person goes into AFib.
Oh, absolutely crucial.
Yeah.
If someone with known WPW develops AFib, you cannot give them the standard AV nodal blocking drugs like verapamil or diltiazem.
Why not? What happens?
Because those drugs block the normal AV node pathway, but they don't touch the accessory pathway. So all those chaotic atrial impulses from the AFib can suddenly fly down the fast accessory pathway, potentially triggering a dangerously fast, even fatal ventricular rhythm. Very bad news.
Okay, critical point there. Let's back up slightly to the P wave itself, the first little bump. What can its shape tell us about the atria?
The P wave gives great clues about atrial size. If it's tall and peaked, like a little mountain peak, we call that P pulmonale.
P pulmonale, suggesting the lungs.
Exactly. It points towards right atrial enlargement, often seen in patients with chronic lung disease like COPD, where the right heart is straining.
Okay. And the other pattern, if the P wave is wide, maybe has a notch in it, looks kind of like an M.
That's P mitral, and that suggests left atrial enlargement, usually linked to problems of the left side of the heart, often involving the mitral valve.
Got it. Tall P means right atrium trouble. Wide P means left atrium trouble. Simple visual cues. Okay, we've done conduction. Now, repolarization. Here's where it gets really interesting, particularly how the T wave acts like a reporter for electrolyte levels. ##3. The T wave and electrolyte extremes. K plus focus.
Yeah, the T wave, that represents the ventricles resetting electrically, and it's incredibly sensitive to potassium, K plus bam. Too much potassium, hyperkalemia, or too little, hypokalemia, gives you really distinct and, frankly, scary ECG changes.
Let's take high potassium first. Hyperkalemia. That speeds up repolarization, right? So if you suspect high K plus MAM, maybe in someone who missed dialysis, what's the classic ECG sign you look for immediately?
The very first thing, the classic sign, is peaked T waves. They become tall, narrow, almost like a tent shape.
Peaked T's. That's the alarm bell.
Absolutely. It's
Yeah.
a major warning sign, especially in kidney failure patients. And the really worrying thing is how quickly it can get worse.
Okay, explain that progression. What happens next if the potassium keeps rising?
Well, after the peaked T waves, the P waves start to flatten out, they get smaller, and then they can disappear completely.
P waves just vanish.
Yeah. And then the QRS complex starts to widen, gets broader, kind of smeared out, because the high potassium slows down the actual conduction through the ventricles.
Okay, so P waves gone, QRS widening.
And eventually, if it's not treated, the whole thing can degrade into this smooth, undulating sine wave pattern, which is basically pre-arrest. It's incredibly dangerous, requires urgent treatment, usually IV calcium gluconate right away to stabilize the heart muscle cells.
Wow, just an electrolyte shift causing that.
Yeah.
Terrifying. Okay, what about the other end? Low potassium, hypokalemia. That delays repolarization. What does that look like?
So with low K plus occur, the T waves do the opposite. They flatten out or can even invert, go downwards. But the real hallmark is often the appearance of a U wave.
A U wave, what's that?
It's another little bump that appears after the T wave. So the classic look is sometimes called the two humps. You see the QRS, then a flattened T wave, then this prominent U wave right after it.
Huh. Two humps. And when might you see that pattern clinically?
Often in patients who are losing potassium, maybe through aggressive diuretic use, like with furosemide, or significant GI losses like vomiting or diarrhea.
Okay, electrolytes covered. Let's move to arguably the most critical part for emergency diagnosis, the ST segment. That flat line normally between the QRS and the T wave. Deviations here mean trouble, right? Like heart attack territory.
Exactly. The ST segment should normally be flat, isoelectric, right on the baseline. If it goes up or down significantly, that indicates myocardial injury or ischemia. This is where we diagnose MIs.
STEMI. We hear that acronym all the time. ST elevation myocardial infarction. What are the key ECG findings that define it? You need more than just any ST elevation, right?
Correct. There are basically three main criteria. First, the ST elevation itself. It needs to be significant, usually defined as at least 1 millimeter high, that's one small square, in the limb leads.
Okay. 1 millimeter in leads like I2, 3, AVL, AVF.
Right. Or at least 2 millimeters high in the precordial leads, the chest leads, V1 through V6.
2 millimeters there. Okay, what's the second criterion?
It'd have to be in contiguous leads. That means leads that are looking at the same neighborhood, the same wall of the heart. For example, leads 2, 3, and AVF all look at the inferior wall. If you see ST elevation on all three, that's significant. V1 to V4 look at the anterior wall, usually supplied by the LAD artery.
So localized elevation in neighboring leads. Got it. And the third thing, the real clincher.
Reciprocal changes. This is huge. If you have ST elevation in the leads looking at the injured area, you should see ST depression in the leads looking at the opposite wall.
Ah, like a mirror image effect.
Kind of. That combination of localized elevation plus reciprocal depression strongly points towards an acute full-thickness injury, a STEMI. If you just see ST depression without elevation, that might be an NSTEMI, a non-ST elevation MI, suggesting partial thickness injury.
Okay. Now, one common challenge I know is telling a STEMI, apart from pericarditis, inflammation of the sac around the heart, because that can also cause ST elevation. How do we differentiate?
That's a really key distinction, yeah. Pericarditis typically causes diffuse ST elevation, meaning you see it in almost all the leads, not just one localized area.
Okay, widespread versus localized. What about the shape?
The shape is often different too. Pericarditis elevation is often concave, kind of like a smiley face. STEMI elevation tends to be convex, more like a dome or tombstone shape.
Mhm.
And critically, pericarditis usually lacks those reciprocal ST depressions we see in STEMI. And you might also see PR segment depression with pericarditis, which you typically don't see in STEMI. So diffuse concave elevation, maybe PR depression, no reciprocal changes, think pericarditis. Localized convex elevation with reciprocal changes, think STEMI.
Very helpful. Okay, quick fire on key rhythms. Just the absolute essential identifiers. Atrial fibrillation.
Irregular rhythm, no clear P waves, just a chaotic, wavy baseline, big stroke risk.
Atrial flutter.
Look for the sawtooth pattern, those regular sharp flutter waves, often conducting down to the ventricles in a set ratio, like 2.1 or 3.1, looks like the edge of a saw.
And third-degree AV block. Complete heart block.
Total disconnect. The P waves march along at their own atrial rate, and the QRS complexes march along at their own slower ventricular rate. There's absolutely no relationship between them. Ps and QRSs are completely dissociated. Needs a pacemaker urgently.
Right. Okay, one last electrical concept before we talk treatment. Cardiac axis. Briefly, how can we use just two leads, say lead-I and lead-AVF, to get a quick idea of the axis, and why does it matter?
Yeah, the axis tells you the main direction of the heart's electrical forces. Using lead-I, which points left, and lead-AVF, which points down, is the quick way. If both QRS complexes are mostly positive, pointing upwards, the axis is normal.
Both thumbs up, normal axis.
Okay. If lead-I is positive, thumb up, but AVF is negative, thumb down, the axis is deviated to the left axis deviation, often a clue for left ventricular hypertrophy or maybe a left bundle branch block.
Got it. Left thumb up, right thumb down, left axis deviation, and the other way.
If lead-I is negative, thumb down, and AVF is positive, thumb up, that's right axis deviation. Points towards problems on the right side, like right ventricular hypertrophy, maybe from pulmonary hypertension or something straining the right ventricle. It's another piece of the puzzle.
Okay, so we can spot the STEMI on the ECG, but knowing is only half the battle. The next step is action, because as they say, time is muscle. Underlying that STEMI is usually a plaque rupture, a clot completely blocking an artery.
Right, causing that full thickness transmural ischemia. And every minute that artery stays blocked, more heart muscle dies. So reperfusion, opening that artery back up, is the absolute priority. Our sources really hammer home the critical time targets.
The gold standard treatment is getting the patient to a cath lab for PCI, percutaneous coronary intervention. Basically, angioplasty and stenting. What's the time goal there?
Door to balloon time. From the moment the patient hits the hospital door to the moment the balloon opens the artery, it needs to be 90 minutes or less. That's the standard of care.
90 minutes, door to balloon. But what happens if the patient shows up at a hospital that doesn't have a cath lab? Many smaller or rural hospitals don't. Transfer takes time.
That's a critical decision point.
Yeah.
If you estimate that you cannot get the patient to a PCI-capable hospital and get that balloon inflated within 120 minutes of the first medical contact.
Okay, so 2 hours total time from first contact to balloon, if you can't make that window.
Then you switch strategy. You use fibrinolytic therapy, clot-busting drugs, thrombolytics, and the goal for that is a door-to-needle time of 30 minutes or less. Give the drug fast.
30 minutes door to needle if PCI isn't feasible within 120 minutes. Let's walk through a quick scenario. Patient hits a community hospital ER, confirms STEMI on ECG. The nearest cath lab is a 90-minute transfer away, so getting the balloon inflated will definitely take longer than 120 minutes, maybe like 150 minutes total. What do you do?
No question. Since the transfer time blows past that 120-minute PCI window, you give the fibrinolytics right there, right now. Aim to get that needle in within 30 minutes of arrival at the community hospital. Then you arrange the transfer. Open the artery first. That's the priority. Hashtag outdraw.
So what does this all mean? Well, we've kind of built a practical framework, haven't we? Start with the grid, the math, the squares, the rate. Then check the conduction pathways, PR interval, QRS width, P wave shape. Then zoom in on those critical ST and T wave changes that signal ischemia, injury, or those dangerous electrolyte problems like potassium shifts.
And the real power here is linking that electrical map directly to those urgent clinical decisions. Seconds really do count, and the ECG is often your fastest guide.
Absolutely. We've focused a lot on the electrical side, spotting the acute injury. But it's important to remember, as our sources point out, the story isn't over just because the ECG looks better or the artery's open. Electrical recovery doesn't mean the structure is safe yet.
That's right. The damage has been done.
So here's something to think about as you digest all this. A final provocative thought. We know ST elevation in certain leads points to injury in a specific heart wall, right? Inferior wall, anterior wall. But what are the potential mechanical disasters that can happen days after that initial injury, even if the artery was opened quickly? Think about the structures inside the heart that might have been damaged by the lack of blood flow.
Like, what could tear? What could rupture later on once that damaged muscle tissue becomes weak and necrotic? Could the location of that initial STEMI, say, inferior versus anterior, actually predict which mechanical complication you need to worry about most in the following days? Something like a papillary muscle rupture causing sudden valve failure, or even a hole developing between the ventricles. That electrical map today might just tell you where the structural time bomb is ticking for next week.